A warm welcome to one and all. This is Dr. Sunil Manuel, Associate Professor from the Department of Orthopedics. The topic that we'll be covering today would be fractures of the patella. So at the outset, let me congratulate all of you for getting promoted as COVID warriors. So it's nice to have that name and that tag, but it should also come with a lot of sincerity and commitment towards what you're doing. So all the best to you for whatever you're doing with whatever knowledge that you have. Definitely it will be a source of support and strength for the people whom you are trying to get in touch with, because the patient or the recipient of your calls or your guidance just sees you as a doctor. So that is what is important. More than the instructions that you give, it is the fact that you are trying to make yourself available to that person that is more important. Having said that, I would still say personally, don't venture out of your house to go out and help people, because things are definitely not safe, and you people are still not trained to be able to protect yourself. So self-protection is the most important thing. Okay, so moving on to patella fractures. Okay, so basically I think there's a mistake in this slide. It says sesamoid bone. So those two words don't go well. I don't like calling a sesamoid as a bone. To qualify as a bone, it has to be a bone. So what is a sesamoid? A sesamoid is nothing but a calcification within the tendon of any muscle. So within the tendon of any muscle, if you have a localized area of calcification, that localized area of calcification is called a sesamoid. So we have a few sesamoids in the body. However, the largest sesamoid in the body is the patella. So this patella becomes a sesamoid. So basically what's happening is you have this tendon, the tendon of the quadriceps femoris. As it comes right in front of the knee, just in level with the femoral condyle, the patellar tendon suddenly calcifies. And this calcification, because when we do an X-ray, we see it like a bone. We see it as a bone in an X-ray. We call it a bone. However, technically speaking, the patella is not a bone. So it is a sesamoid. And then the calcification ends here at the lower pole of the patella. And from there, we have the extended patellar tendon. So this is the largest sesamoid in the bone. And why I am emphasizing this fact a lot is because there are a lot of implications of understanding this when you treat a patient with patella fractures. Okay. Meanwhile, I was just going through Wikipedia the other day, and I heard that on Wikipedia, I'm not very sure, that because none of the medical textbooks tell it, that the word patella actually originates from India. So that is something unusual, that a medical terminology has a word from India. However, that's the fact, and it's on Wikipedia. Right. So now coming to understanding the extensor apparatus of the knee. So to understand this tiny bone here that is called the patella, you need to zoom out and understand this whole structure that you're seeing here. This is called the extensor apparatus of the knee. Any understanding of patella, what it does and how it functions is, you can say, incomplete without being able to understand the extensor apparatus of the knee. So what is this extensor apparatus? This extensor apparatus is the group of muscles, tendon, retinaculum and sesamoid that helps in extension of the knee. So that is what it is called, the extensor apparatus. So what are the structures that make the extensor apparatus? The first structure that makes up the extensor apparatus is the quadriceps femoris. The quadriceps femoris, as the name indicates, is a combination of 4 different muscles. That would be the vastus lateralis, the vastus medialis, the vastus intermedius, and layered on top of it would be the rectus femoris. So this quadriceps femoris is the muscle power that powers the knee, and this quadriceps femoris is the muscle power that powers the extension of the knee, innervated by the femoral nerve. So you can see that the femoral nerve is a very short nerve. It just comes in here, immediately innervates the quadriceps femoris, and then the rest of it is just a sensory supply. That's because the main job of the femoral nerve is done here in innervating the quadriceps femoris. And as we go down, if you take, so that's the zoom out view. Now I'll zoom in to the area around the patella. What's happening here? So now the quadriceps femoris is coming, the lateralis, the medialis, the intermedius is at the back, and the rectus femoris. All of them, as they come here, they condense to form this white structure. This condensed white structure is called the quadriceps tendon. So all these muscles end up being muscles and becomes the tendon. So that's the quadriceps tendon. And this quadriceps tendon is what is attached to the sesamoid, which is called the patella. And from the quadriceps tendon, as you go down, you have the patellar tendon. And this patellar tendon goes down and attaches to a protuberance anterior to the proximal tibia, which is called the tibial tuberosity. Now this whole structure is reinforced on either side by these white layers here, and that would be the medial retinaculum, and on the lateral side you have the lateral retinaculum, along with other structures like the iliotibial band and things like that. Some other interesting structures in this picture is this is the pes anserinus and this is the iliotibial band, but anyway we will not focus on that. So now what is the extensor apparatus? The complete extensor apparatus is nothing but the quadriceps femoris, the quadriceps tendon, the patella, the retinaculum, the patellar tendon, as well as the tibial tuberosity. All of them working together and working along with the power supply, that is innervation provided by the femoral nerve, is what helps in extension of the knee. Okay, so this is the lateral picture. What you can see it from the side, you will see that the quadriceps muscle comes in, becomes the quadriceps tendon, the patella is here, the patellar tendon or the patellar tendon is there, and then it goes and gets attached to the tibial tuberosity. So these are the parts of the extensor apparatus of the knee. Now so this is the extensor apparatus in full function. So you can see the quadriceps femoris, so a little exaggerated view, because this is, you can see everything here, the rectus femoris here, the vastus medialis, the vastus lateralis. If you appreciate, the vastus medialis inserts much lower than the vastus lateralis. Okay, right. And suddenly there is a disappearance, there is a huge groove here. This groove is because it is no longer muscular. So this bodybuilder can build only muscles, he cannot build tendon. So this is tendinous area of the quadriceps tendon, and from there it goes into the patella. We are not able to see his patella because of his muscle bulk, and then this nice structure that you see, this linear structure, is the patellar tendon, and it is now helping him extend his knee and give him an extension of the knee. And because he is doing it against resistance, there is a severe muscle contraction or a fantastic muscle contraction. So that's a beautiful display. Now you will tell me like, sir, actually I am not able to appreciate that in my body. So our bodies are something like this. Okay, so what we have is, again, you have your patella. We also have all these structures. It's just that it's not as big as the guy in the previous slide. So what we have is like, if you're at home, you can actually extend your knee and take a good look at your knee. This is the time to take a good look at your knee, whether your extensor apparatus is fine. The most important thing to know is that you should have complete extension like this. You don't have to have any resistance. Just do a simple extension of the knee against gravity, and you will see that this is the patella sitting here, the muscles coming in, there is a sudden depression there, that is the area of the quadriceps, and from the patella there goes the patellar tendon attached to the tibial tuberosity here, giving the extension. Okay, right. So if you are not able to find this groove of the quadriceps tendon, then you seriously have to do some workout, because probably you are very fat. That's what it means. Okay, right. So now I'll just once again tell you about the extensor apparatus. The quadriceps femoris muscle, the four of them, vastus medialis, lateralis, intermedius, all of them. Quadriceps tendon, the patella, the retinaculum, the patella tendon and the tibial tuberosity. All of them, the power supply is from the femoral nerve. If the femoral nerve power supply is gone, none of them will be able to function. So in my class, I'll try to put in some pearls here and there. I'll call them clinical pearls. So I would want all of you to gather as many pearls as possible by the end of the class. So therefore, a tear in any one of the above disrupts the extensor apparatus. So what I'm trying to tell you is that it's not just about patella fracture. It's not just about retinacular tear. It's also if you have a tear in your quadriceps femoris muscles. This happens if you are working out in the gym or in sports injuries, especially when it is unmonitored and you have gone beyond your capacity. You can have something called a quadriceps femoris muscle tear. You can also have a quadriceps tendon tear. How does this happen? Normally the quadriceps tendon doesn't tear like that. However, if there is a penetrating injury to the knee, that is an injury with a sharp instrument like a sword or a sickle or a knife, then a person can end up with a quadriceps tendon tear. Then if you have a patella tendon injury, again because of penetrating injury, patella tendon is normally very strong, it doesn't give way, but sometimes this can happen. And tibial tuberosity fracture. Now when do you have a tibial tuberosity fracture? If you have a proximal tibia fracture, then you can have a tibial tuberosity fracture. An injury in any one of them and the patella and the retinaculum can cause a disruption of the extensor apparatus. So this is something that you should understand. So when you see a patient or a person who is not able to completely extend his knee like that, then you are thinking that this person has probably something called an extensor lag. Okay, and if there is a lag, then you want to know or you want to investigate what this patient has got. So I'll come to extensor lag a little later. So let's move on. So one more, so obviously the next pearl that you should be able to pick up is that a patella fracture for me as a clinician is not a fracture where I'm trying to fix the bone and get the reduction like in a long bone. Here it is essentially a tear in the extensor apparatus of the knee. So that is very important for all of you to understand. So for me, a patella fracture is, apart from being a bony injury, a tear in the extensor apparatus of the knee. Okay, so now I've been ranting about this extensor apparatus since the last 10 minutes. So why is this important? This is important because the extensor apparatus is very important for a normal gait, and these are the phases of a normal gait. You have something called a stance phase and something called a swing phase. So in the stance phase, there is this phase that is called a mid stance phase, and in the mid stance phase, let me zoom that out. Yeah, so in the mid stance phase, you will see that this guy's leg, which is in contact with the ground, is absolutely straight, and this is possible because of a normal extensor apparatus of the knee. If the extensor apparatus of the knee is disrupted, the person will not be able to stand on one leg with complete extension of the knee. That is very important. The other thing is, you will be wondering, sir, I hardly stand on one leg. Very rarely we stand on one leg. That's true. But when we are walking, momentarily, for a brief moment of a small duration, I can say that all of us stand on one leg. That is during the, I'll show you this place. Okay, single support phase. So in single support phase, basically during this phase, and during this phase, the person is essentially standing on one leg. Okay, so again, then he goes to double support phase, and again he goes to single support phase. So there are times that we are standing on one leg, and this is something that we need to understand. Okay, so what happens if this extensor apparatus is injured or if it is damaged? Then you have a problem. When the person is walking, there is a tendency for the knee to buckle because the extensor apparatus is not intact. However, he knows that he doesn't want the extensor apparatus to buckle because he wants to propel himself forward. And at that time, what the person will do is, he will take his hand and press it against the front of the knee. And this is called a hand to knee gait. It is classically seen in poliomyelitis, where it is because of the weakness of the quadriceps femoris. So amongst all the things in the extensor apparatus, I told you about the quadriceps femoris. So if the quadriceps femoris is weak, then again you have a deficiency in the extensor apparatus. So this is the importance of the extensor apparatus. Now there are some other strange things that the patella does. So I want you to just have a good idea about all of that, which will give you a better perspective of why patella fracture is so important. The most important thing about the patella fracture, it is the two pearls that I already told you, that a patella fracture is a fracture of the extensor apparatus or is a disruption of the extensor apparatus. There are some other things that the patella does for efficiency. Now in this picture, it's very clear to you that the quadriceps is functioning in this direction, but the pull of the patellar tendon is in this direction. So this is akin to how you use a pulley. So we all know and we've all studied about pulleys. Pulleys give us the ability to direct a force in the direction that is advantageous to us. This guy can actually come to the center of the well and pull up the water. But the problem is, if he comes to the center of the well, he's obviously going to fall into the well. So therefore, this pulley is able to help him transmit a downward pull and transmit a downward pull into an upward pull of the water. So same thing is happening in a patella. So what the patella is doing is, patella is acting like this pulley. So it's at the peak of the pulley, and the quadriceps pull or the quadriceps contraction is nothing but the guy pulling downwards. But you have the tibia which needs to come upwards because of the pull of the patellar tendon, and that is happening on this limb. So the force in this direction is getting transmitted in this direction. It wouldn't have been possible if not for the calcification of the patella. If the patella was not calcified, if that area was not calcified, and if there was no sesamoid there, then this pulley effect couldn't have happened. So imagine now, if you make a pulley out of, imagine a scenario where you have two pulleys. One pulley made out of wood and the other pulley made out of metal. So these days we don't see many wells now, but of course most pulleys are made out of metal. Why do you want a pulley made out of metal? We want a pulley made out of metal so that it can last for a long time. Similarly, nature has agreed that we need some calcification in the tendon, because this tendon has to go like this and act in this direction, and therefore this calcification is what is what actually makes the sesamoid calcify, and therefore the bone patella. Okay, so the other thing is, the patella also acts as a lever. So I'm bringing in a lot of physics here, but it's very important that you understand this concept also before we go into the actual class that you have to understand, that's about patella fractures. So the thing is, like here basically what's happening is, this guy is using a lever and this is the fulcrum. So I should have mentioned it as the patella acts as a fulcrum. So here is where the patella is sitting, and what the patella is doing is, the pull of the quadriceps in that direction is the power that this guy is giving. The fulcrum is here and it is actually transmitting the power down to the tibial tuberosity. Now the only technical thing that I want you to understand here is that there is going to be a lot of friction between the underside of the stick or the rod that he is using and the fulcrum. Similarly, if the patella is articulating with the femur, the patella's posterior surface is articulating with the femoral condyle. So when the posterior surface of the patella articulates with the femoral condyle, definitely in this action there is going to be a lot of stress here. Therefore, what nature has done? Nature has given the thickest cartilage in the body. This is the thickest cartilage in the body on the posterior surface of the patella, where it articulates with the trochlea. So this is the magic of nature, what nature has done, because the forces that are generated here are so extreme that the posterior surface of the patella is literally rubbing against the femoral condyle. And to protect that area and to give a smooth gliding in that area, nature has given the thickest hyaline cartilage to the posterior surface of the patella. So if you get this message across, if I can get this message across to you, that would be fantastic. Otherwise, you don't have to bother much about the lever. And the last thing that the patella does, so I am bringing in a lot of mechanics and physics here, but this is what makes it interesting. Now imagine this person who has gone into one leg that is gone, or this leg that's gone into extension. But to reach extension, we know that the extensor apparatus has to act. But what is the starting point? The starting point is a folded leg. From a folded leg, he has to take his leg out into full extension. Now for him to do that, if the patella was not there, so let's deduct this patella, and if only the quadriceps muscle was there, it would be much closer to the body, and from there it would come glide along the femoral condyle and go and hit against the tibial tuberosity. If that was happening, then the efficiency in the muscle wouldn't have been there, and therefore the quadriceps would have to put in a severe amount of force to actually get this work done. But what the patella is helping do here is the patella is giving a lift to the muscle. So by pushing the force outwards, the patella is giving a higher angle of entry for the patellar tendon to transmit the force into the tibial tuberosity. So what the patella is doing? Patella is lifting up the quadriceps femoris tendon. And how is it is able to lift the quadriceps femoris tendon? Because it is calcified. If it was not calcified, the patella wouldn't have been able to give this lift. So these three things are as important as the importance of the extensor apparatus. Patella acts as a pulley, patella acts as a fulcrum, patellar's posterior cartilage is the thickest cartilage in the human body, and the patella also gives a lift to the quadriceps femoris, thereby making it super efficient. Otherwise, to get the leg lifted from here till here, all of us would have had to have huge thighs with huge quadriceps muscle. That would be very inefficient, and therefore nature has given us this patella here, which is giving a lift. Okay, so now let's come back to the classic way a teacher teaches, which is to take a student through the classification of fracture. So everything is self-explanatory here. So this is undisplaced fracture, a simple transverse fracture. I would relish to have a case like this, but these cases are very rare. Lower pole fracture, though actually the images in all the books, in all your textbooks will show this picture. The most of the fractures that we are receiving these days are these two, either a lower pole fracture or a multifragmented fracture. Okay, multifragmented undisplaced here and multifragmented displaced. So we receive this and this. This is quite rare, a vertical patella fracture, quite a rare fracture. Now coming to undisplaced fracture, rare fracture, and multifragmented undisplaced, rare fracture, transverse fracture were supposed to be common, but now rare. This is common, right? Okay, so this is the presentation. This is how the patient will come to us. You will notice that the patient will have pain, the patient will have swelling, but what would be characteristic is the contusion. That's because most of the patella fractures are direct impact fracture. There's a direct impact to the patella, and that is what has actually caused the fracture. And therefore, because the patient has got a patella fracture, because the patient has got a disruption in his extensor apparatus, obviously he will have inability to move the knee. Now, the transverse fracture usually happens not because of direct impact, but because of an eccentric contraction of the quadriceps muscle. So during the fall, when the person is trying to protect himself, or in some other sport mechanisms, what happens is that quadriceps goes into a violent contraction to save itself from being injured, and in that process what happens, the patella, there is so much enormous force on the patella, and let us understand that the quadriceps tendon and the patellar tendon are not going to give way. So the poor chap, there is the patella which is bony, and it is going to break into a transverse fracture. But the lower pole fractures, the multifragmented fractures, the multifragmented displaced fractures, all of them are typically due to a direct impact on the knee. So you will be able to appreciate this. Now when you do an imaging, to actually evaluate a patella fracture, all that we need to do is to do a simple plain X-ray. And it requires a little bit of experience to see the fracture here. So here I am tracing the fracture. This is the upper border of the fracture. The lower border usually is a little difficult to trace. Especially so, we will be able to pick up the fracture in AP view with some experience, but will not be able to pick up much of the comminution or the other pieces. But the lateral view will beautifully tell us regarding the fracture configuration and what kind of fracture we are dealing with. Now, when you are seeing this picture on the X-ray, as a clinician, I am imagining this. This is what I want you to understand. So what you have, because we are doing this X-ray, and X-ray is only going to show us the bones, what we are seeing is that we have a fragment here and a fragment here. Okay, so we have a patella fracture. But what I am seeing is, I am seeing much more than that. What is there here? This is the patella fracture. This is the other pole of the patella fracture, the superior pole or the superior fragment, and the inferior fragment with varying degrees of retinacular tears. So I am already seeing this when I see the X-ray, and when I take the patient into the surgery and I open up the patient, I am not just concentrating on the fracture fragments. I am also trying to assess the depth and the extent and the severity of the retinacular tear. The more the retinacular tear suggests that it is a high velocity injury. Not only that, the principle of surgeries and whatever surgeries I am going to show you now, I will be only showing you the patella fracture being fixed. But I want you to understand that after we fix the patella fracture, I am going to do a thorough repair of the medial retinaculum and the lateral retinaculum. If I don't repair the medial retinaculum and the lateral retinaculum, then the stress of the implants on the patella fracture is going to be so high that either the implant will give way or the surgery will fail, or even if the fracture unites, having tears in the medial and lateral retinaculum will give me a poor result in my follow-up. Okay, so the next pearl is, what about treatment? So what is the aim of treatment? Okay, I told you patella is part of the extensor apparatus of the knee. So my job is to restore the extensor apparatus of the knee. Okay, so the first simplest treatment that we can offer somebody would be a non-operative treatment. So I wouldn't offer a non-operative treatment for every patient. It would be offered only for patients who are having either undisplaced transverse fractures or undisplaced multifragmented fracture. Because the moment the fracture displaces, there is no role of plaster treatment. So only for the undisplaced transverse fracture and the undisplaced multifragmented fracture, I am able to offer a plaster treatment. So this is a cylinder cast. Okay, or in some cases we can even use a knee immobilizer. I would definitely prefer a cast, and this cast basically ends just above the ankle. So we used to use the cylinder cast when we were postgraduate students. These days we don't prefer to use a cylinder cast because the lower end of this cast tends to start rubbing on the Achilles tendon and causes irritation to the patient. So we go for an above knee cast in extension, that is, we don't flex the knee. So here you can see the patient's knee is kept in extension. Why? Because any flexion of the knee is going to displace the fracture. And we are going to keep this cast for 6 weeks. And at the end of 6 weeks, we are going to take off the cast, assess the healing status on an X-ray, and then slowly, gently mobilize the patient. Okay, so now what about surgeries? So the first and the most common surgery that we do for treatment of a patella fracture would be an open reduction and internal fixation with tension band wiring. So what we do here, and this again, open reduction internal fixation with tension band wiring, is an appropriate surgery for transverse fractures which are displaced. Okay, so this is an ideal case for open reduction internal fixation with tension band wiring. So the transverse displaced fracture. Okay, in other words, yeah, even this is also a nice transverse displaced fracture, an ideal scenario for open reduction internal fixation. Because what I have is a big fragment here and a big fragment here. I need 2 big chunks to be able to do the surgery, that is the tension band wiring. So what we do is we put in Kirschner wires and we bind it up with a stainless steel wire, that is a stainless steel knot, and we then allow the patient to gently mobilize the knee. So what is the advantage of doing this surgery, open reduction internal fixation with tension band wiring? We can actually theoretically allow the person to mobilize the knee as early as possible. However, practically the patient will be in a lot of pain because of the associated tears in the retinaculum on the medial and the lateral side, and also because of the surgical wound. But anyway, at the end of 2 weeks, if we are happy with the wound healing, definitely we can start the mobilization. And the concept here is something called a tension band wiring. That's again a totally different concept in physics, and probably that will take another half an hour for me to explain. So I think I've already given you enough physics for today. So we'll keep tension band wiring to maybe some other class. So basically what happens in tension band wiring, it is a technique that as students you should know that it's a technique in which distraction forces. A fracture has got forces of distraction that is always trying to keep the fragments from coming close to each other. So it takes all the distractive forces across the fracture and converts it into compression forces. So I'll explain that. Let me see whether I can explain that to you without using physics. So basically, before this fixation was done, you will notice that the fracture fragments were pulling outwards because of the pull of the quadriceps femoris. Now the surgeon, what he does is he brings in the fragments together and then he locks it up in this configuration. Once he locks it up in this configuration, when the patient contracts his quadriceps, then the pulling force will become a compression force. So the force of distraction which was there in the fracture has now been converted by the surgeon into a force of compression. And compression in a fracture is what is essential for bone healing. And also to make matters interesting, we are dealing with a cancellous bone. Patella is a cancellous bone, and therefore the fracture will heal readily once you give this kind of a construct. Now this tension band principle is not just used in the patella fracture, it is also used for olecranon fractures in the upper limb, that is the proximal ulna, and the medial malleolus fractures and the lateral malleolus fractures. So even these areas also we can use the tension band principle. We commonly use it for the olecranon fractures, medial malleolus fractures, as much as we use it for the patella fractures. Lateral malleolus, these days we have other implants, and therefore tension band principle is not used anymore, though it can be theoretically used. Okay. So now I want you to just note that I am giving you all the treatment options. So this was number 1, ORIF with tension band wiring. Now let's come to ORIF, open reduction internal fixation with screws. So now this is about screw fixation, fixing the fracture with screws. So here again, this kind of a fixation would be ideal if you have a vertically split fracture. Also you can use it in a transverse fracture also. There is nothing wrong in using it in a transverse fracture. So much so these days there are a lot of surgeons who prefer to fix patella with screws. Why? Because the previous surgery that I told you, the tension band wire, these Kirschner wires once the fracture unites, they tend to start pressing when the patient goes in for complete flexion of the knee. And therefore many patients return back telling that they want removal of the implant. So in those cases, the screw fixation is much better because there is no irritation of the skin by the screws. So this is also a very good technique. It can be used both for vertical fractures as well as for horizontal fractures, but it has to be transverse fractures and fractures without comminution. Okay, so we are going up the ladder of difficulty. Now the next thing is, what if you have a stellate fracture, or not a stellate fracture, a fracture with multifragmentary, and it is displaced. If a fracture is multifragmentary and displaced like this, then you'll have to go for something called a circlage wires. You will appreciate that the tension band wiring technique, which was there for a transverse fracture, will not work in this scenario. So here we are being forced to use a circlage wire. These days somehow we are seeing a lot of cases where patients are coming with fracture fragments or fracture configurations like this, and apart from the tension band wiring, which is the most common surgery, we have started to do a lot of ORIF with circlage wiring. So you can see here, it's not 2-part, it is multiple part. This is one of our cases only, and this has been fixed with a circlage wiring. This is about partial patelectomy. So here what basically we are doing is, definitely this is our case. But here what is happening is, you will see that this entire patella, that the lower pole of the patella is comminuted, but you have the upper pole which is relatively good bone. So now what you do is, you remove all this comminuted piece, that is, you enucleate them, like how you enucleate the eye. Similarly, you enucleate them. You take the raw end of the patella tendon and you bring it up to the bone and suture it with suture anchors, or suture it with ethibond stitch. These are non-absorbable sutures, so they will remain in the body forever. So these are very strong sutures and they are going to hold the thing. Only catch is, it is not as strong as the tension band wiring, and therefore you will have to protect this patient with a plaster for 4 weeks. So we do that, we protect the patient for 4 weeks. This is called a partial patellectomy. This is a fantastic surgery if done well, especially when you have comminuted lower pole fractures, or the lower half of the patella is injured. And now I'll tell you why the lower part is more injured than the upper part. Whenever somebody's knee buckles and they fall with landing on their knee, it is the lower pole of the patella that actually comes in contact with the ground. So that is where this surgery becomes very important. Here we are doing apart from doing a partial patellectomy, we are actually threading it through the bones. So here we are taking these stitches into the distal fragment where the patella tendon is there, and we are actually threading it out into the proximal fragment. So this is just before the threads are cut. After just immediately after that, we will cut the threads. Now what you will see here is that this gives a better hold, because unlike the previous one where it is sutured very close to the patellar fragment, here the thread goes through and through the bone. So it makes a big difference. Now coming to another technique where people are using suture anchors. So these are something called anchors. They look like small tops, and basically the suture goes through that, and then you can do a neat braiding of the patellar tendon and fix it here. So all these techniques are partial patellectomy techniques. Okay, now the last technique that we can use when you are dealing with a patella fracture would be a total patellectomy. Now this is a desperate case scenario where the entire patella is fractured into unreconstructible pieces. But now you have a situation here. The whole all that I told you, patella is the lever, patella is the pulley, patella is the fulcrum, patella is the lift, everything goes for a toss here, because the patella itself is broken into multiple pieces. But the first point that I told you, patella is part of the extensor apparatus. So what we have decided here is that if the patella is part of the extensor apparatus, and if the other structures in the extensor apparatus are still there, then we are going to sacrifice this patella by enucleating it, just like you enucleate the eye, and then take the quadriceps tendon proximally and the patella tendon distally, bring them together and suture them. So that is the plan here. So here the entire patella is taken out and it is sutured like this. So this is called a total patellectomy. So there is another way of suturing that is called a purse string suturing. So you know this, here the sutures are taken all around, and then when they are tightened, you get a nice round mass here, and that mass sits like this. Now the advantage of that mass was that sometimes what happens is, a few months after doing this surgery, you will notice that this patient's, that mass that we have created there is actually going to condense with fibrous tissue, because nature has a way of healing things, and nature heals soft tissue injuries with fibrous tissue. So what happens to this fibrous tissue mass is, as the patient runs his hand on that fibrous tissue mass, it feels a little soft, feels a little firm and rounded, and gives him a feeling of having a patella there. So it may not be as bony and strong and big as the original patella, but definitely it makes up for that and gives the patient a good feel. In fact, all the patellectomies, total patellectomies that I personally do, I like to do the purse string suture surgery rather than the one that I mentioned here, where you enucleate and go for a straight stitch. So this doesn't give that effect. Now once you do a total patellectomy, we are going to get out of the theatre and tell the patient, and of course before the surgery also we have told the patient that, boss, we have taken off your patella, so don't expect complete extension of the knee. So that is what we are going to tell the patient very clearly. So he is not going to have a complete extension. However, what we are going to do is, so all the biomechanical advantages or the rosy things that we told in the beginning are not going to be there. But in any bad situation, we can still work out for the best case scenario. So what we are going to do is, we are going to take this guy through really good amount of physiotherapy. That's only after 6 weeks, after all this heals. And with that physiotherapy, we are going to help this guy build up his quadriceps muscle. The more he can build up his quadriceps muscles, he can make up for the deficiency in the power or the biomechanical advantages offered by the patella. So this is how. So what happens is, on one side we are sacrificing the patella, on the other side we have the quadriceps, which is a structure which can be through exercise and through physiotherapy, a structure that can be strengthened. So if all of you start doing quadriceps exercises today onwards, at the end of 1 month, definitely you will have stronger quadriceps. Similarly, for the patient also, we are trying to build up a stronger quadriceps, and by giving the patient a stronger quadriceps, we are going to reduce his deficiency in walking. And I told you about the hand to knee gait. Definitely the patient will not have a hand to knee gait, that's for sure, but the patient will have an extensor lag. I'll explain that. Now, coming to the complications. So the first complication and the most difficult to treat complication is a non-union. So this happens when the patella fracture is neglected. So here you can see that the patella is really, the proximal fragment really goes up. That's because of the constant pull, initially the pull and later on the contracture of the quadriceps muscle. It's a very, very difficult scenario to treat. And also you will notice that the fracture ends are rounded and the fracture ends are sclerosed. So this is a non-union. The distal fragment doesn't go anywhere because it is held here by the patella tendon. Now the other thing that you can have is, if your patella surgery has not come out well, or if there is any injury to the cartilage, so this is the underside of the patella, then in the long run the patients with patella fractures can have a condition called patellofemoral osteoarthritis. This is not knee osteoarthritis. Knee osteoarthritis is between femur and tibia. This is patellofemoral. It's a third component as part of the knee joint. So this is something called a patellofemoral osteoarthritis, and this is something that causes anterior knee joint pain. So this is one more complication of patella fractures. And the last thing is the extensor lag. So if the patella fracture is not treated properly, or if the patient after union of the fracture has not done enough quadriceps exercise, then the patient will not have the complete extension that all of you that I was able to demonstrate all of you in the beginning of the class. So this is what we call an extensor lag. Now this looks like a flexion deformity of the knee. So how do you differentiate between an extensor lag and the flexion deformity of the knee? So there what you do is, for an extensor lag, you stand beside the patient. The patient is definitely able to bring his knee only till here, but the last amount of movement is still there in an extensor lag, done passively by the examiner. So if the examiner is able to passively take the knee into full extension. However, if you have a fixed flexion deformity of the knee, so when do you have a fixed flexion deformity of the knee? We have a fixed flexion deformity of the knee when we have any knee pathology like osteoarthritis or infections in the knee. In such cases, we have a condition called fixed flexion deformity of the knee. In the fixed flexion deformity of the knee, the examiner will not be able to passively take the knee into full extension. So that is how a student differentiates between an extensor lag versus a fixed flexion of the knee. So fixed flexion deformity of the knee. So those are the complications of patella fractures. So with this, I think we have come to the end of the class. So thank you very much for joining, and all the best. Thank you.